So the next topic is by Dr. Jason. He has used plenty of IPCL. Those are the Indian implantable contact lens that is available. Cost factor is a major issue. So all patients can't afford the Star ICL. So this is a good option that surgeons like us have resorted to. So Dr. Jason is going to talk about the Indian implants and his experience regarding that.
Good morning, all. I'm going to talk about my experience with Indian implantable contact lens. So I have done only 93 IPCLs of 51 patients for a period of 7 years. You can see initially we were using IPCLs without holes, 34 without holes, and later we started using IPCLs with hole. You can see toric is outnumbering non-toric lens, 55 toric, and the lowest diopter implanted was 3 diopter, and the highest was 22 diopter. And regarding the results, we got 80% got uncorrected visual acuity 6 in 3 months. And 90% were within 0.5 diopter of spherical equivalent, and 98% were within 1 diopter spherical equivalent after 3 months. And 97% of eyes attained or improved their pre-operative best corrected visual acuity. These are the measurements what we take for IPCL implantation, refraction of course, and K1, K2, ACD, anterior chamber depth, the lens thickness and axial length from IOL master. When we do topography and take corneal thickness, and this corneal thickness has to be reduced from the chamber depth obtained from IOL master to get the depth from the endothelium to anterior lens capsule. And ACD less than 2.8 is avoided from implantation. And white we still are using the caliper, manual electronic caliper. We are not using, not started using the OCT based angle to angle measurement. And online power calculator will provide you the IOL power. And we have to see the endothelial cell count and IOP for all cases. And there are only 2 steps you have to be careful about implantation. That is, one is loading and the other one is haptic placement. What I do is I make a pocket with the viscoelastic beneath the iris so that I get a space there so that I can easily implant the 4 haptics of the lens. Initial days we were using this without hole lens, so I used to go beneath the IOL and wash the viscoelastic. And these days that is not done because the central hole, through the central hole you can aspirate the viscoelastic. And initially we were not having the central hole and we were doing the iridectomy. I used to do all intraoperative iridectomy. And initially I used to put pilocarpine also. So and this is the only intraoperative complication which I got, that is the lens went upside down. And these lenses, when it goes upside down, it is difficult. Unlike your PCIOL, your capsular bag space is not there. And turning the lens is extremely difficult, and it has to be done very carefully with viscoelastic coverage. So that was the only intraoperative complication. And other issues were anterior subcapsular cataract. two eyes developed anterior subcapsular cataract, and one was a 32-year-old patient, 17 diopter implanted patient. Another one was 25-year-old, 11 diopter implanted person. And both were having no central hole at the, for the IOL. And the lens vault was adequate. And the first patient, cataract developed within 1 year of implantation. Initially, vision was okay, but within 16 months, it became 618. So surgical intervention was done for that patient. And vision improved from 618 to 69 after surgery. And the second patient developed anterior subcapsular cataract following an RD surgery. That video I'll be showing later. And this is one thing where your implantation is more difficult and explantation is so easy actually. Through the tunnel, you don't have to enlarge your tunnel. This lens will come out through the tunnel. Maybe the other star lens will be easier than this IPCL. So still you can explant the IOL through the same wound. The other complication was increased intraocular pressure. 4 eyes of 3 patients developed increased IOP, and 3 were without hole and 1 patient was with hole. And IOP was always within, below 30 in 3 eyes. And these 3 patients developed immediately after surgery intraocular pressure, and they were managed conservatively with medications. And we could remove all medications in 1 month. So out of 4, 3 was easy to handle. But the 4th patient developed intraocular pressure following RD surgery and IOL RD surgery and silicone oil implantation. But the cataract was not like as you get in silicone oil implantation. This developed after 7 years after implantation, and it was not like the cataract that you get in silicone oil implantation. It was like a anterior subcapsular cataract, that what you get in implantable contact lens. So this patient had intraocular pressure also. So this lens was slightly more difficult than the other lens, but the what you call the exchange of hand technique, it was removed. And it was combined with trabeculectomy because the pressure was very high, above 50. So trabeculectomy was done for that patient. Patient is still under follow-up, and time being the pressure is normal. And this is the other complication I had with implantable contact lens, that is rotation of lens within the sulcus. This patient presented 14th day of postoperative, 14th postoperative day, and this was repositioned through a paracentesis without a viscular. Actually, maybe white-to-white issue was there. That may be the reason. But fortunately, this lens remained there after that. So the vision, I could regain, that patient could regain the vision. So to conclude, significant reduction of myopia and astigmatism were achieved in all cases. Anterior subcapsular cataract and raised IOP was the most frequently seen complication. And whole IPCL decreases the risk of cataract formation and raised IOP. Thank you.
You didn't mention about the mark on the haptic when you inject the lens. IPCL.
Yeah, actually, you mean the haptic marks. Somebody else mentioned that trailing one should be on to your right hand, the leading should be to your left hand.
What is the lowest spherical correction? Why did the patient opt for ICL?
Pardon?
Three spheres what you corrected, no?
Yeah,
minus
that patient, corneal thickness was too low. It was not fit for LASIK. And patient was very keen on spectacle freedom, so we implanted 3 diopter.
Thank you, Jason, for your wonderful talk and your experience on IPCL.